We are live, my friends, and welcome to Soma and Synapse, where myself, Michael Hamm, and Dr. Mark Olson discuss burgeoning, interesting topics relating to nervous system regulation, holistic healthcare, physical medicine, um, somatic work, etc. And Mark, let me just. I don't know if we need to add you as a co-host or pin us both, but why don't you say hello real quick, Mark, and then we'll talk about what we're talking about today.
All right. Yeah. Hello, everyone. Thanks for joining us. I'm super excited that we're continuing this discussion. Today, we'll be talking about fascia. Does it exist? No, no, okay. We got that covered. But uh, we're going to see where this goes. We're having some technical issues here. We're going to smooth out. Does it smooth out on your side?
Seems smooth. Seems like people are able to see you, see me. If you're
Okay.
seeing this, my friends, whether you're watching after the fact or live, go ahead and put a comment down. We will be monitoring comments and we will respond to each one. So thank you so much for joining the discussion. Um, of the most crucial debate in our fascia clinical reasoning smackdown is how do you pronounce fascia? Is it fascia or fascia? Um, Actually, Mark, the reason I'm excited for this discussion is that we, I think, share a commitment to talk about body work and embodied practices with a grounding in evidence. But I think we have different traditions that we've been trained in when it comes to, or at least different ways we've navigated the world of fascia and fascia, and especially when it comes to how much of a uh, framework is it in our actual clinical reasoning? How do we make a decision about how to interpret the history given to us by a client or patient? How do we make decisions about how to use our manual therapeutic skills, the depth of our contact, or the connection, the sequencing of moves, or the prognosis of a person describing their symptoms and their aspirations to us? Fascia has, for me, in writ large, fascia been uh, a framework that has been helpful, I think. And yet, I think you and I would both agree that, like any medical model that is capacious and hazy in its borders, many times it's a framework that is in want of a more grounded scientific discussion. And so both you and I have tried to find ways of talking about fascia that are less wrong, shall we say.
Yeah.
Um,
Or less binary.
yeah. So with that in mind, Mark, I think I want to kick things off by just kind of knocking out the simplistic versions of this. So I want to sort of uh, imagine that you and I are both body workers of some stripe. We're both working in the same clinic, spa, office, and we're at the water cooler, leaning back between seeing folks. And I want to just give you some short versions of pop science fascia talk, and I would love your response to that. Imagine that we are friends, but we're the kinds of friends who like to punch each other in the shoulder, and so you can be as direct and merciless as you are motivated to be. So Mark, yeah, I'm gonna let you fill your water cup. Hope you're having a good day today, man. My first patient came in today, and these fascially restricted upper cross syndrome patients. This guy came in, he was like, yeah, man, I mean, I know that, like, I know that I sit in with the wrong posture in my chair, and I know that because my mother told me I had bad posture, and then my teacher told me I had bad posture, and then I also know that I'm like, a morally suspect person who doesn't try hard enough in life, and then the ergonomics expert told me that I had bad posture at work. And so now I know that unless I maintain the most virtuous position at all times while typing on my keyboard, I am consigned to a life of restriction within my fascial cage. And what I need from you, body worker, is uh, is almost like a sort of catharsis. I need a release from my physical fascial cage so that I can have a chance at a pain-free life. What would you say to that?
Yeah, that's what your client said to you
Yes,
here?
I'm
Yeah.
paraphrasing.
Paraphrasing. Okay. Well, what would I say to the client? Um, I have to, I think I would say, well, it's understandable that you think that way. I had people tell me those things too growing up, and it kind of makes intuitive sense because, if you have objects laying around and they get deformed after a while, and we're used to thinking about things, physical objects in that way. Uh, and so it's easy to think, well, that's the way bodies are going to work, but there really isn't any evidence for that idea that that's how bodies work. There's no relationship between like the person's actual posture and their reported pain experience. Like people who have more pain don't have worse posture according to what we think of as worse. And we don't, and going into good posture doesn't actually alleviate pain. Oftentimes it actually makes it worse. And the other thing is that we can't even really change it. There's nothing that you can do in a session that would actually change the material physically. Like the material that our bodies are made of does not actually mold within an hour by pushing on it. It doesn't, that's not how it works. It develops over time based on how you're using it, or over weeks and months. So, uh, yeah, so that'd be part of the thing that I would say to them.
Well, you've knocked out all of my, several of my subsequent hypothetical pop science things. Number one, like if I'm coming to you and I'm a real gym rat, and I really like to get to the gym, and I say, yeah, but I show up at the gym and I'm feeling really tight and restricted in my movement. And so what I need is a round of foam rolling on every square centimeter of my body, and I need a some kind of jigsaw reciprocating fascia blaster gun that I can sort of pummel all of my fascia, um, so that then I can feel loose. And I need to hydrate my fascia. Number one, I need to stretch it, and number two and number three, I need to kind of redistribute it over my skeleton so that I can then go work out more freely and have access to better movement. What do you say to that?
Yeah, well, I would say, I hear that you're feeling tight, and I certainly would want to help you feel less of that. And maybe some of those things that you mentioned, some of the physical things that you mentioned, uh, we could talk about whether that seems to help you feel that way. Um, and, I would, that'd be great if that's actually going to make you feel that way. But I would want to have a little longer conversation about like, why do you think that does that? Because I don't, and if it only lasts for 2 days, why is that? Like this, so if you changed that fascia, then it did it unchange in a period of time. Why would it do that?
Mark, fascial release requires constant vigilance. My body is like a cornstarch water mixture. Unless I tone it and then release it constantly, I'm going to melt and or turn into some mortar stuck to a brick.
Mm, mm, mm. Yeah. Well, I understand why you might think that things get like stuck together. Maybe you've seen some videos of like cadavers where it looks like things are getting stuck together with white fuzzy stuff. That's very convincing and makes it seem like things get stuck together. But the thing is that
Mark, I can feel it happening right now. I'm
really,
feeling white and fuzzy at this moment.
really fuzzy, not warm
Yeah.
and fuzzy, just white and fuzzy.
Warmth comes and goes.
Well, we want you to feel warm and fuzzy, but we don't want you to get fuzzy. And especially because that fuzziness, if you've seen those videos, is actually something that only happens in dead people. So we don't want that kind of fuzziness. So it's those kinds of things that we think of as things sticking together. That makes sense that we think that. We all played with glue as kids, but it doesn't happen. It doesn't happen on our body. There's no evidence for sticky things sticking together that we need to unstuck. But it feels
Um,
that way.
Thank you, Mark. That was an excellent smackdown, takedown of several sort of ways of talking about uh, uh, fascia, connective tissue. I want to track a couple things you were doing there. Number one, you were in each instance you were validating the direct experience of a person in terms of their pain experience, in terms of their, shall we say, there's something like postural dysphoria, or a sense of not feeling quite in the right place in terms of your shape, and it probably has some relationship to dysmorphia, but it's something else as well, like just not feeling quite in or on or rightly rightly configured. And you were validating that. You were also validating the feeling of tightness and restriction. So you were starting by anchoring, I think, to something real, which is the direct experience of a person. Um, uh, and then you were putting space between that and the best language that this person has found to describe it, right?
Yeah.
Um,
If I could just interject, I would
yeah.
say, I'm thinking in terms of the subjective experience versus the objective, what's subjectively happening. So I'm trying to switch the conversation from the subjective to the subjective and keep it focused on the subjective.
Yes, and one of my favorite things to talk about, which I think we might talk about toward the end, is that the subjective is typically, because we all do SOAP charting, the subjective is typically thought about as just a patient domain.
Mhm.
But in fact, I think there's an equally important subjective to make space for, which is the practitioner subjective.
Absolutely.
So if I were rewriting the sort of SOAP chart, I would say patient subjective, practitioner subjective,
Hmm.
objective,
Yeah.
and make space for that second category, because a lot of practitioners are wishing for a way to speak about the rigor of their direct perception, and the meaningfulness of it. They're trying to seek that, but they, in order to seem legitimate, they've learned to construe it as objective information, when in fact it's subjective, but it might be valuable, but it's not the kind of thing you can verify or build a
Yeah.
factual understanding on.
Yeah. We should swing back
um
around to that at the end of this, I
yeah,
think.
yeah. The last thing I just want to track, that you said, and I'll just link it in the comments, is you were talking about white and fuzzy stuff, and this is a famous, and I think a really wonderful video by Gil Hedley, anatomist, called "The Fuzz Speech." And Gil has said exactly what I'm about to say, which is, um, uh, that in that video there was a cadaver, and there was a picture, a video of blunt dissection of one tissue layer from another, which means you make a cut, and then you have this two layers that are separable just with your fingertip. Basically, you peel back a layer of skin or a layer of muscle from its larger sheath, and what you see at that unzipping interface, that sliding interface, now in a cadaver, is that there is a white fuzz, almost like a micro Velcro, that is unpeeling between the two. And then in the video, there's sort of like that is spoken of as a metaphor for why it's nice to move, to keep our interfaces sliding and gliding. And so that's definitely, check out that fuzz speech video from Gil, and as well as subsequent discussions kind of about that from him. Um, uh, I think I want to also circle back to what that interface was and how we can think about it in humans, in living humans, because yes, indeed, that is what cadavers interfaces do. But I think that space between two fascial layers is an interesting space to think about when it comes to clinical reasoning.
Indeed.
Speaking of which, a couple other sort of things I think is useful to say. When we speak about fascia or fascia, um, there's a distinction I think useful between what an anatomist would call fascia, which is an irregular membrane of dense collagen and other connective tissue fibers. So that's proper fascia, a membrane, a plane of non-parallel collagen fibers that wraps or divides or connects something. Of course, many times when we speak about fascia in the world of physical medicine or clinical reasoning, we might mean something bigger, like the fascial system or the body's fibrillar network or the web of connective tissues. And that means that like this irregular membrane of fascia is continuous with instances of collagen where it's regular, like this. That's called regular dense connective tissue. You see this in tendons and ligaments and aponeuroses and parts of joint capsules. So that's fascia. This is sort of regular dense connective tissue. And where this transitions into this, uh, let's say this kind of irregular membrane tends to have one type of innervation, one type of blood supply, one type of function. When you get into specialized connective tissues that are more regular or something, you also get specialized receptors. I think you get specialized sort of mechanoreceptivity in those places. That's a claim I'm making, which you can interrogate.
I don't know. I'm not familiar with that kind of detail.
Yeah, I guess I mean to say the type of innervation that tends to happen in like any sort of irregular fascial membrane tends to be sort of free nerve endings, C fibers, and sympathetic motor. But you don't tend to see in a plane like that a lot of concentration of
Hmm.
of Ruffini end organs or of muscle spindles or Golgi tendon organs. You tend to see those, and this is from I think Peter Hoying and et al. But I'll try to find the image. You tend to see those where two fascial planes converge, or where there's a fascial plane turning into a tendon or an aponeurosis. So my understanding is that where the mechanical connective tissue architecture is doing something interesting when it comes to movement or having to move in specialized ways, that's where the nervous system has evolved listening posts. So you tend to see, for example, in the forearm, you tend to see, we used to think of like muscle spindles or happening at specific places, but it turns out that both Golgi tendon organs and muscle spindles tend to concentrate in the denser walls between muscle compartments, as opposed to the sort of like the compartmental wall itself is relatively devoid of those. But if you sink into the valley between two compartments of extensor muscle, you have a greater concentration of those specialized mechanoreceptors. Um,
I didn't know that.
Well, I'm having fun so far. Any thoughts that you want to sort of like opine about? I want to kind of go into a couple of interesting clinical cases in my real practice in just a minute. But yeah, what brings you into this discussion, or how have you felt it compelling to talk about?
Yeah, well, I think what you were just talking about, we could go down some very long rabbit hole with that for a while, but we probably wouldn't get to the other things that we probably want to talk about. So I'm going to leave that to the side. Um, and you just asked me what other things. I mean, I think, we want to talk about these nuanced ways of thinking about fascia rather than these I would say, more binary ways of talking about it, right? So, um, yeah, let's have that nuanced discussion. Let's get into like, where does fascia become relevant in the that it's different than the ways in which it's not, like the ways that we often talk about it. And I have these binary, yes, it is, no, it isn't discussions. Like, what's the middle place that, where things are really interesting and relevant to talk about?
Yeah. Well, let's talk about one situation in particular. Um, I've heard you speak of when it comes to the world of adhesions, the world of where uh, there are, I think, both within ourselves in our own bodies, as well as when we're feeling others' bodies, there are instances of seeming restriction, mobility limitation in the tissues, layer to layer. They seem to be restricted, and sometimes there is a uh, there is a discovery of like uh, change within a few seconds to a few minutes where something suddenly shifts. Um, and so that's a discussion of adhesions and of fascial plasticity. Um, uh, how fast do things change in response to what? And indeed, like how important is it to think about sticky bits in our fascia and whether they change. And I've heard you say recently in a comment like no evidence for adhesions. Um, and so I want you to expand upon that for a moment. Then I have a couple questions for you.
Yeah, my understanding is that the things that we're imagining as adhesions, the things that we feel that we call adhesions, oftentimes there's when surgeons are cutting there, they don't see anything like what we're describing. Um, like what is being described. So um, there's a subjective client saying, I feel something, I imagine it's an adhesion. The subjective practitioner is feeling something and imagining it's whatever it is. But there isn't any objective evidence for that very thing. Of course, there's scarring that happens from injuries and that kind of thing, but that's not what we're talking about.
Yeah, so I would agree with part of that. I would have a slightly different take. Number one, just as we said at the beginning of the discussion, it's essential when we speak about adhesions and perceived tissue restriction to put space between the direct experience that we're having of restriction and what may or may not be under the skin, and to assume that one can accurately perceive a sliding restriction between layers, or a contracture of tissue, and know exactly how deep it is or what it is or how malleable it is with your hands. Like that would be fusing, that would be adhering two concepts too closely together. And so putting space between um, the actual thing happening in the tissue and the perception of that is essential. I would say that, and so that means that I think that I would say that adhesions have been spoken of and detected in many cases by surgeons and histologists and anatomists, and indeed have been treated uh, as sometimes a problem to be solved, especially in like post-abdominal surgeries, post-surgical situations where you've got a post-surgical adhesion. Um,
Surgical, yeah.
however, yeah. Um, and so there's an open question to me about like um, on what time scale, so there are adhesions, but their correlation with our perception of tissue restriction is not known. And so the question for anyone in practice is, you're working with somebody, they have a really sticky bit of tissue. um, what's your understanding of what's happening under the skin and how best to change it?
Wait, I want to.
This.
You just said
Go
there
ahead.
are adhesions. So we agree that there are adhesions with surgical and there's adhesions with injuries. But we're also agreeing that there are not in other like normal situations. Is that accurate?
I think it's accurate to say that in various cases, I mean, I think surgery and injury is a good are two cases. I'm not sure if there's. I think of adhesions as one consequence of inflammatory healing. That essentially happens when you have a some injury or rupture, and then after that injury or rupture, there's an immune response wherein fibrin and sort of clotting factors are delivered. That fibrin is an excellent glue that sticks everything together initially, and then as the body heals and movement becomes more possible, there's a process called fibrinolysis where there is a dissolving of that, and some or all of the initial glue dissolves, restoring normal tissue function. But I think that there's a range of outcomes there, one of which is that there remains some more stickiness between layers formerly sliding. Whether that is a problem to be treated, and to what degree that is perceptible by a practitioner or a patient is an open question to me. Does that sound about right to you?
Yeah, yeah. But I also want to just point out that we're still talking in the realm of injury and that kind of thing, where some people say things like, if you just sit around too much, you're gonna, adhesions will form and things will stick together. And I
Ah,
just
yes.
so I just want to be clear that there's no I don't know of any evidence for that.
I would agree with that.
Okay.
I think perhaps in that way, in that sense, the term adhesion um, might be a stand-in for I feel remodeled. I feel habituated to a certain shape that I would like to work on and change in some way. Does that seem true for you? Yeah.
Yeah, absolutely. I mean, it is a stand-in. Yeah, absolutely.
So uh, classically speaking, for example, with take something like the subcutaneous thickenings that we might call Schultz bands, where uh, where there are places where the subdermal, the superficial fascia, is more densely populated with collagen, and these are places where the sort of fatty content of skin is thinner, and where there is a little more sort of uh, density of connective tissue, at least in the subcutaneous layer, and maybe even in the super surface of the myofascia. Um, and somebody might say, "I've got adhesions in these layers." They might be taking this imagery and saying, "What I'm feeling." This image gives me a map for what I'm feeling, and what I'm feeling is restricted in these banded ways. That could be from the patient or the practitioner's perspective. Does that make sense to you?
Yeah,
As
so
a
the
as a
quality
Yeah.
of the tissue is indeed different in those regions, and that's being named as an adhesion. That feels like another example, a different example of. Do you have clients who have talked about that with?
Um, I I mean, I imagine that some of those clients have been either they are trained themselves in some kind of fascially informed movement or bodywork style, or there are veterans of seeing practitioners who use figurative language, physiologic language. So they've learned a certain lexicon
Mhm.
um, of how to describe their movement restriction. Um, this always brings up the question, which we could talk about in many different cases of somebody comes into you, whom you are trying to help. And part of your job is to live in their world a little bit and leverage their understanding. Because as a provider of healthcare, I am importantly ignorant of what it's like to be the person I'm trying to help. And so when they come with a language that describes their experience of their body, it's not usually the first move, right, to challenge that language, because
Mhm.
my job is actually to hear their experience and to and then to kind of make good decisions based on that. But over time, suppose that I have a good therapeutic relationship, I might be perceiving the potential for harm or at least limitation of certain ways of thinking about the body. So if somebody thinks that they're constantly under threat of adhesion to themselves, because of sitting in the wrong position or something, it might be a kindness to gently remodel their understanding of how their own body works, right? And so there's always a tactical question about, like, when during the therapeutic relationship does it behoove us to challenge a model versus doing the work of hearing things as they are describing it.
Definitely easier to remodel an understanding than to remodel the tissue.
Um, uh, you know, we don't have good enough solvents yet. Now, let's talk about adhesions that we think are likely to exist. Let's talk about post-surgical adhesions, and to be sure, not all surgery is definitely resulting in an adhesion, but many times that you cleave living layers of tissue and then let things reform, there is some degree of changed relationship between sliding layers. And occasionally that can become a medical issue worth trying to treat. So for example, the great and the cantankerous Jeffrey Bove, I would say a pretty skeptical, pretty evidence-based scientist, and equally cantankerous Susan Chappell, RMT from Squamish, BC, teamed up, massage therapist and former chiropractor, now how would you say, integrative physical medicine researcher Jeffrey Bove did a couple of studies when it came to an adhesion model in a rat. And the interesting thing about this study, admittedly, an animal model study done over a relatively short time scale, is that not only could the massage therapist in question detect where the adhesion was in the abdomen, but they also could detect that change was possible on that time scale. And I've got a barking dog in the background. Hey, buddy, listen, we're trying to have a ground discussion. Okay, I know this stuff gets you riled up every time. Okay, so I think we got an Amazon delivery here. So with my enthusiastic dog barking in the background, here's my question for you. So let me just give you one more bit of context. It turns out that rats make excellent, at least make an interesting animal model when it comes to massage research, because unlike mice, rats kind of like massage, and so it's at least when they're trained up to it, the rats tend to enjoy it. And so I visited this lab, and you can have a rat like lying in your cradled hands like this, and so the rat is facing you, and you're cradling the rat, and then your thumbs are doing the belly massage with the rat, or the twizzling of their little paws or something like that. So in this model, an experimental adhesion was made, meaning under anesthesia, opening the abdomen, and then gently using a toothbrush to just slightly brush on the visceral peritoneum, on some aspect of the gut. And then you just close up the abdomen, and you allow a week or two to pass, maybe 3 weeks, and then there is a fusing of some layer. A very predictable post-surgical adhesion gets formed between a layer, a part of bowel, and the parietal peritoneum, the abdominal wall. Now, the location of that adhesion was variable, and they did a crossover design where some rats got an adhesion, some rats didn't, and then some rats got massage and some rats didn't. And so in this model, they were able to show that Susan was able to locate where the adhesion was, and in many cases, and Susan had kind of a fairly forceful visceral massage technique, was able to cleave some or all of that adhesion, including one case where it was like, I didn't get the whole thing. Some of it was left over. And then later Jeffrey checked and was like, okay, actually, that's exactly what happened. There was a bit of adhesion left over. In a parallel study, they also found that the rats that received post-abdominal massage had lower levels of inflammation and faster recovery time when it came to post-operative ileus, that's say paralysis of the gut. So here's a
And this was
case,
blind, right?
I'm sorry,
It was blind.
blind. Susan did not know
Okay.
uh, uh, which rats had adhesions and where the adhesions were. So in this case,
Wait. Just a minute, clarify.
yeah,
Um, she didn't know, but like we wouldn't see the scar from the surgery.
the surface scar, of course, is visible, but where the experimental adhesion was done um, uh, had some variability to it. So it was what was happening under the skin, which was not visible and not yeah. So of course, there's many ways in which this small study of rats doesn't translate to people, and we can't make claims about all kinds of things. Notably, um, human beings are bigger, their abdominal cavities are larger. There's lots more potential complexity there. Um, Number two, the time scale. Rats have different metabolism, different healing time scale. So uh, it's very, very different to be massaging a rat 3 weeks post-surgery than massaging a person 8 months post-surgery. Very different dynamics in terms of the changeability, I think, of those healing layers. However, I will say it did in that case, I think, create some questions for me in terms of how, like, is it possible to feel where a layer is sticky? I think Susan, in that case, was able to locate the sticky interface pretty well. And I think there was an ability to apply force in such a way. And Susan would say, it doesn't work universally, but if you happen to have an adhesion in the right place, you can stabilize one layer while moving another layer. And her model is, if you do that in just the right way, you can create a selective force on that sliding interface. I've heard that, at least in humans, saying there's no way for us to select between layers. And I think Susan would say there's some way for us to select between layers.
Hmm.
Um,
Yeah.
uh, and I'll
Did
say,
they
yeah, go ahead.
did they do any studies, uh, like anything like this more than 3 weeks out? That
I need to double check on the exact timeline, but it was
okay.
a small number of weeks that the rats. All rats were evaluated 7 days following
7 days.
surgery, um, and then there was an immediate post-mortem adhesion evaluation, which is a very euphemistic way of saying they looked inside the rats after death. Um,
Hmm.
and so
It
and
doesn't
so it was,
surprise
yeah, yeah.
it doesn't surprise me that this would work this way soon thereafter. It's because the scar is forming. It takes, I mean, in humans, right? There's like 2 years of a scar forming, if I understand correctly. Um, so presumably there would be a period after which this isn't going to work on rats either.
I,
Right?
I would agree with that. Yeah, I'd say
Yeah.
that's likely. So I think the time scale is a major limitation. The fact that they're rats is a major limitation. The study design, I would love to see this done on people in some safe time scale, because that crossover design really isolates, I think, uh, both the manual skills, the detection skills of the manual therapist, as well as the changeability of the adhesive tissue.
Yeah.
And if there's even some medical benefit, forget about cleaving or lysing those adhesions. What if targeting them in some way altered the physiology of the local tissues? That going to the place where there was a healing process, maybe there's autonomic dysregulation there, maybe there's nerve entrapment there, um, maybe there's some inflammatory, sizzling, long persisting, half completed inflammatory process, and maybe going there helps re-regulate those dynamics and help somebody feel less in pain or move better. This was the other case I was going to offer you, which is a real human case in my practice. So a few years back, I had a patient who came in with very debilitating symptoms of neuralgia paresthetica, which was a condition where the sort of lateral part of the thigh was experiencing a lot of numbness and sort of sensory discomfort. And so this is to do with the lateral cutaneous nerve of the thigh, which descends from the upper lumbars, tucks inside the iliac fossa, so on the inside of the ilium, and then spills out the most lateral aspect of the inguinal canal, descending and immediately coursing down and laterally to sort of cover the whole lateral thigh down to the knee. And so folks with neuralgia paresthetica are experiencing numbness and pain, sensory dysfunction in their lateral thigh. And this is commonly, people are advised to stop wearing tight belts. They're advised to look at their lumbar spine and make sure there isn't any compression of the lumbar foramina. But in my experience, there's very little examination of the journey that the lateral lumbar-cutaneous nerve has to undergo between the upper lumbar area and its exit from the inguinal canal. And that journey involves traveling along the outside of the visceral cavity, tucked in, going first on the ventral aspect of QL, the quadratus lumborum, and then descending to be on the interior aspect, really lining the iliacus muscle on either side. So if you sort of find your own ASIS here, anterior superior iliac spine, and you just put about 2 fingers width up from there on the iliac crest, just pivot your fingertips in, roughly there on your fingertips is where the lateral femorocutaneous nerve is sitting on the surface of the iliacus. Well, I had a patient a couple of years ago with persistent, unremitting neuralgia paresthetica for months, and some history of abdominal surgery. And she tried, perineural injections. She tried weighting. She tried stretching and PT and foam rolling and all kinds of stuff to try to help the lateral thigh get better. And so I said, let's take a look. No history of lumbar injury. And as we were palpating along your path of this nerve, I noticed that on one half of your abdomen, the unaffected side, there was seemingly ease of mobility between the large intestine and the outer abdominal wall. That meant that I had my finger pads where I thought the large intestine was. I depressed the abdominal wall until I felt like I was atop some slippery bubble, and then I slid laterally until I felt like I was in a valley between that bubble and the muscular abdominal wall. And right now I'm feeling / hallucinating that on my finger pads, there is a pressurized volume that I can displace one way. And then my fingertips are resting in a kind of deep valley. And then on my fingernails, there's this kind of muscular abdominal wall. So that's what I was doing on the other side. And I noticed that on the left side, that valley was a lot shallower. My perception of her descending colon was that it was barely separable from the abdominal wall. And especially when I got to this iliac fossa and I tried to dip into that ilium space, I was expecting to be able to go way deeper with my fingertips. In fact, there was no admittance of my fingertips into this space between sigmoid colon and ilium. So that was a much shallower valley on one side than the other. Not my expectation. And when I pressed into here, there was familiar sensory sensation down the line. So I think it was reasonable in that case for me to say something here is causally related to this condition,
Mm-hmm.
um, and uh, and something here feels anomalously less mobile than the other side, at least based on my expectation. So with that, I said, well, let's spend some time here, and I tried to sort of gently probe how much change is possible in this sticky interface, shall we say, what I was feeling as a sort of lack of mobility between layers. And I will say that in the course of the session, there was the valley that I was feeling that was preventing my fingertips um, uh, sinking. The valley seemed to get deeper. There was more allowance of my fingertips by a reflexive or mechanical change. Also, there was a temperature change. So there was autonomic change, and it felt like more fluidity in that area as well. Also, there was improvement in symptoms. There was, the patch of numbness shrunk long before I even got to the thigh or the inguinal canal. The patch of numbness shrunk to a smaller area before and after the session. And so here is me, practitioner, with an idea in my head of post-surgical adhesion. And I'm trying my best not to either, be definite about it, but I'm also trying to, but I'm also using that imagery to guide my hands into a place I thought was helpful. And what would you say to that case, or what questions would you have for me?
Mm-hmm. Well, I mean, it seems very reasonable to conclude, I was obviously she has a nerve issue, right? So, and any number of things can happen along the way. I think there's an over focus in our field of, oh, if there's a nerve problem, it has to be at the spine. But, no, there's no rule on a stone tablet that says that. The nerve can be affected anywhere. And you said she had surgery, so it's reasonable to think that adhesions form from that. I was a little curious where the surgery was exactly as relationship to where you were pointing. Um, I'm curious about, so how did that change? Okay, so there's two things. One is that you affected a change in her. So I'm imagining that you moved that adhesion, or maybe it's not an adhesion, maybe it's just fascial layers around in such a way that the nerve was happier for some amount of time. I don't know how long she had relief for. Um, but you also said that it felt different to you. And I'm really curious about that. Like, why, what do we imagine happened in that small time frame? Because presumably that whatever form there had been there for a while. And
Yeah,
I don't easily imagine that changing if it's adhesive material it, in a small amount of time. So, um, but perhaps uh, you know, muscles around that area relaxed because there was less pain. I mean, I don't know. I could make up stuff, but I don't really know. Why would there be a change in your experience and her pliability?
yeah. Well, number one, part of the reason I brought this up because it was one of these cases where the beneficial change of working in that area was not just for a day or two, it was a persistent improvement. So something we did changed an underlying dynamic in a session, meaning that I think she had a lot of potential change that just needed a little more help, right? It wasn't like I had the magic that she needed, but it was like something we did activated or facilitated a latent change that was ready to happen, and there really was persistent improvement in her symptoms after that.
Was this
Um,
within 2 years of her surgery or after that?
I think it was within those 2 years. Yeah,
Okay.
I can't remember. The
So she's
surgical
kind
site
of
was
like the
not.
rat.
Yeah, maybe. I'm not saying that necessarily uh, that there was necessarily a change in the level of adhesion in this patient. Although I'd say it's possible. If, for example, we find that human beings have some changeability, some plasticity of their adhesions within 2 years of a surgery, I'd say that's an amazing finding. We should try to do our best to help mobilize, because it's definitely safe to work on folks, many folks post-surgically,
I
you know.
think I think that's what physical therapists would say. Um,
Yeah.
I've had physical therapists say that to me after surgeries I've had. Um, and, explain that if we work on this scar right now, we can minimize it because and what they would do, and I don't know if they still do this. Hopefully somebody listening, can tell us, um, apply light pressure. It was like wearing like a pad on the scar all the time, all day long. And they said that that would change the ratio of growth of the scar to the breaking down of it. But both of those are happening all at the same time at the beginning. So, um, I just took them at their word that that's the case. So I would think that this person, something similar. I know that when I was experiencing that myself, I was massaging my scar myself, and there was one day where it seemed like I had a huge step, a huge leap in range of motion, because something seemed to break. Uh, so it does seem to me that within those first 2 years after a surgery, that there's this, and this was in the first 2 months, or even 2 weeks maybe. So, um,
Yeah.
yeah,
So I think one point of agreement we're finding is that within a certain time scale of an adhesion or other sort of wound healing process, um, as you said in the beginning of our live stream, the material of our bodies is somewhat amenable to mechanical change. Uh, Although the certitude with which we can aim for that, or diagnose it or prognose it, is somewhat limited. Would you agree with that?
yes,
Yeah.
yes. I mean, changing it, we have to define what we're changing, not just anything. We can't just change anything, but yeah.
Yeah. The last thing I'll say on this, and I want to just have a brief note about, like, I want to ask you about perception, is just sometimes we talk about fascia as if it's one thing or if it's just a single layer. And I think that in many cases, my best outcomes as a body worker are when there is uh, I'm able to create temporary changes that create a window of time where the nervous system can learn something new about its own capacities or its own threat perception or something like that. So I can downregulate somebody's pain for a period of hours to days, and then they try some different movement, and all of a sudden that feeds back on a different behavior over time, which then creates a change in their their persistent symptoms or capacities, et cetera. And sometimes that's how I think about the potential for change in the fascial system, that I am not going to be able to stretch an IT band or a thoracolumbar fascia in a session. But I do think it might be possible that those sliding interfaces, which are not composed of dense collagen, but can indeed, as we see post pneumonia, they can get a little bit sticky. They can move less. It does exist as a model in my head. Can I help sliding interfaces, the ones around nerves and tendons or around organs and serous membranes, to move a little more in the space of a session than they were moving at the beginning? And for the period of time where they're moving a little more, maybe they could have gone to a yoga class or gone for a run, they're on my table instead. Um, that provides a different sensory environment for the body, a different, a different, a counterfactual to the normal way they perceive their body to exist, and that may result in behavior change, which then feeds into the remodeling over time of their connective tissues.
Mhm.
So that's kind of how I think about fascial change, the plasticity of fascia on different timescales. In the short term, within a session, I'm not trying to cleave or stretch a layer of tissue, but I am perhaps encouraging um, sliding between layers insofar as it produces a changed perception of self.
Yeah, so change of perception, change of behavior, change of tissues. So that's the time scale sequence, right? Yeah. And we just don't really know what that first that sensation, if it really does involve these moving sliding of layers. That's we're at the theoretical level right there, right? I mean, we can't
Right.
really.
Everything I said definitely could be possible without that layer sliding restoration thing. That's just what I'm hallucinating when I'm doing the work.
Yeah. Yeah, it could be a useful hallucination. It doesn't seem like a harmful one. Like a
Well,
harmful,
you haven't been on my table very much, so you won't see.
but a harmful hallucination is, hey, if we press hard enough, we can get this to move. And then because it actually isn't true, and then we're just pressing on people hard in ways that are damaging, so that's a harmful hallucination. So this one is a useful one. It doesn't seem to be harmful, even if it's not true.
Correct. And I believe in some sense of harm in not necessarily. I believe there is harm in not interrogating uh, one's sense of what's true. So I am, for many reasons, both enjoyment and harm reduction. I'm curious about these discussions with you in terms of getting to what is most likely true, and trying to remodel my own understandings based on that. Um,
Yeah.
Mark, we've left precious little time, but any concluding thoughts about how uh, how perception can be modulated um, with regard to the physical body, either feeling it from within or working with it from without? What's happening in perception that might be different than our like immediate intuitive understanding of it?
Yeah, I think it's worth spending a few extra minutes, maybe go over the hour, just because everybody always asks the question of, oh, can you feel how tight I am? Or, that they have their feeling as a client. And then therapists are always asking, well, what's happening beneath my fingers? I feel things changing. So it seems worthy to, since we've been talking about these
Yeah.
adhesions, we're talking about like what are these experiences? And I just we have to start with that humility of we don't really know what's going on underneath the skin because we have we can't see it. And to even go further back here, just in terms of how perception works, whether it's vision, hearing, touch, anything, it doesn't work in the simple way that we might think, or that we learned in high school, that there's a sensor and then the signal just goes to the brain, and then we're just taking the apple and we're seeing the apple directly. Like that's not how it works at all. Um, there wouldn't even be really hardly a need for a brain if that's how it works. So, uh, what's going on in every sense modality is that bottom up information, that raw data, is being processed and integrated with what we already know about the world. And that happens on a subconscious level. It happens on other levels too. So, what you hear is being filtered by, the kinds of things that you would expect, like a kind of words you might expect somebody to be saying. If I blurt out something, but I'm kind of mumbling, you can make it out, but maybe not immediately. You go, huh? Oh, yeah, yeah, you get what I said 2 seconds later because you started to figure out what were the probable, what are the likely things that I might have said in that context. Same thing with vision. And when we have low resolution data, like for vision, that would be like in a dark place with low contrast. We don't see very well in that context. But if we were cats, we would have a whole world in the low light, low contrast because cats have to see, dark rats in a dark place. Um, so when we have situations where we have low light and low contrast, we are like, oh, there's a UFO. We make up stuff that seems, coherent to us based on things we believe, what we might think it might be. So the same thing is happening with the touch system. And as massage therapists, body workers, we often have low resolution data, especially if we're just holding someone. We're keeping our hands in one place and we're doing it in a still way. That's and sometimes that's a lot like the low light, low contrast situation. So there's a possibility in those situations. I'm not saying that everything you feel in that isn't accurate, but there's a lot of it's ripe for the conditions for the brain to generate like, well, maybe this is what's going on, especially if I have an idea or a belief about what's going on ahead of time. So, I think that we should all come with humility and understanding about that may be what we feel, because an illusion, any visual illusion that we're all familiar with, they all look real to us. I mean, those, parallel lines that don't look parallel, they don't look parallel. Doesn't matter how many times you look at it, they don't look parallel. Same thing with touch. It doesn't matter how many times you feel it. It can feel like it's happening, but it doesn't mean that it is.
And I just want to draw out, I mean, you kind of alluded to it there, but Mark, when you're talking about how these different modalities of perception happen, palpatory, visual, et cetera, you're talking about predictive processing, right? So many times per second, our brain is making a guess as to what the world is inside and out. And we cannot get behind that guess. Everything you're talking about happens prior to conscious choice about the matter, right? The best we can hope for is to update our our understanding of the world so that when we perceive, we can that predictive processing is filtered differently. But we cannot get behind the filter to some real apprehension of the world. Um, and so to know that certainly leads to a certain humility, as well as uh, a sort of perhaps an appreciation for how, if we implicitly give people in our care a model of how the world is inside and out of of the body, we might be affecting their perceptions in good or bad ways over time. And so it means, and we see this in pain metaphors. If a yoga teacher says, now as you pass into this downward facing dog, try not to crunch your hips, or
Mm.
little terms that might evoke ideas of what the body is that can actually end up becoming filters of pain or amplifiers of pain in the future. So being careful with the ways in which we filter our perception, being intentional with that, where and knowing we can't actually escape from that filtration of perception feels
Yeah.
important if we care about getting people better.
Yeah, I mean, there's
Um,
interesting research I
yeah.
just want to mention real quick is people researchers provided heat onto human volunteers in a way that was painful, and then they had them imagine that heat differently. Like this is harmful heat versus this is a warm blanket on a cold day, and they would get different responses out of the, how painful that was based on how they imagined it. So it matters a lot how we imagine what's going on.
Yeah, I completely agree. And the last question I have for you with this has to do with another, a parallel perhaps to another low data healthcare profession, or let's say low resolution, lots of information, but a dim room, which is the world of psychotherapy. You know, another interactive healthcare profession where a person is sitting across from their patient or client and trying to discern the workings of their nervous system on a level of the mind. And uh, and in psychotherapy, there's of course a whole other history of like skeptical interrogation. What do you really know about what's happening in the mind versus like what's your model here, right? But I'd say that many psychotherapists today have been trained in models of the psyche, which are fully admitting that they do not necessarily map onto models of, you know, of cognitive systems as detected by cognitive science or neuroscience, but saying, I think, my model is parts work, that we each contain a multitude of personae that interact, that we have absorbed and interact, and by giving them each a name and a location and a kind of uh, maybe that relates to neuroscience, but this is seemingly an internally consistent therapeutic method, even if it's decoupled from the physiologic reality of the brain. Um, how do you think of that? Is that a valid choice to make for a clinician to say, I'm not making a claim about how the brain works, but this is my way of working. This is my metaphor for the mind, for the nervous system. This is my symbolic landscape. Is there a way to do that helpfully, or are these folks committing a kind of unforgivable act of self-deception?
We're gonna end with this. We need like 3 hours for this.
Sorry.
Okay, so, well, um, I think it's important not to let one's models get in the way, to let the client lead, be a client uh, centered in psychotherapy. So there's a wide range of that in psychotherapy to the extent of, like, we're checking off lists, looking for certain things, and I'm forming a theory about what's going on, and I'm gonna say things based on the theory that I have, versus I'm just gonna be curious with you and I'm gonna facilitate your own exploration, and I don't need to have a model of how it works. So I fall more under that uh, side. However, I certainly think that IFS has contributed great things to psychotherapy, so I'm not trying to suggest otherwise here. That's why we need 3 hours for this.
Well, let me give you an example. Like, yeah, I mean, just something as simple as when you're raising a child, you are also in a sense reparenting yourself. You are encountering behaviors which you yourself have had, and perhaps they resonate with you or some way. That's a simple, at the level that I'm making that claim. I think it's at least a useful prompt for thinking about parenting, right? But I am making no factual claim about that there is some like inner child inside my brain
Yeah.
that is glued to my hippocampus or something like that. Uh, and uh, and so at least potentially there is a way of speaking of a model of the psyche, which, if held loosely, at least leads to interesting questions, perhaps, and not necessarily a rigid method, which I have to, squeeze my client through.
I mean, we have to be able to talk, right? And so what's really going on, is not at the level that we can talk. There's, the organism's trying to survive, it's trying to formulate concepts about the environment, who's safe, and what strategies to use. And so we could talk about it neuroscientifically, right? There's relationships communication between ventral medial prefrontal cortex, who am I, with the amygdala saying like, what do I need to move away from, and the
Wow,
insula.
I'm having an emotional breakthrough as you talk about this. It's
Oh,
great.
good, good, good. It works every time. Um, Insula saying, this is what I'm feeling, and I mean, all these different limbic and prefrontal structures are figuring out how to live and how to act and behave, and then we have to put that into language. Um, and so there's always going to be a leap there. We're never going to speak in the terms like the actual terms, like to be like talking in ones and zeros or something. They can't do that. So we have to be able to communicate well. So I think with IFS, for instance, it's useful to have this idea that there's a protective mechanism, and then there's this longing character, that it wants something. I mean, we can map those on to limbic structures of a protective feature and a desiring feature, and then give them sort of an animated, human quality. Uh,
I'm always inclined to be animist with everything. Um, well, Mark, I want to thank you for your time today. I think this was a really fun discussion. We've gone from the anatomical physiology of fascia and its and sort of trying to navigate both the simplistic and the more subtle versions of what change is possible within a session in fascia, as well as how it might explain our direct perception of movement restriction, pain, et cetera, et cetera. There's so much we haven't talked about,
so
but we ended with kind of I think, the thing that faces all of us if we're trying to help others with the complexity of existing within their bodies and in the world, which is um, uh, how do we keep one foot in the verified and in the sort of known, which is a shifting world, but it's one that I think constrains our methods in useful ways, but also keep a foot in honoring what people's direct perception are, both as practitioners and as recipients of work. Um, and I just want to, I'll put this in the comments, but I want to sort of highlight to y'all that both Dr. Olson and myself teach workshops, teach classes, and you can take those classes either on demand or live. So as one teacher to another, Mark, I appreciate your renewable dedication to weaving these different worlds, and I'm excited. I'm excited to read the comments. My friends, please comment. Even if you're watching this later, we will respond to each comment and hopefully continue the discussion. And we're going to try to do this monthly. So we'll see you next month for another episode of Nerve and Soma.
mhm.
Another,
Thanks, Mike.
hopefully not another Smackdown, but yeah.
Yeah, thanks so much. See you next time.
See you next time. And thank you everyone for tuning in.